Hello, everybody. Welcome to the FUSE webinar for residents put up by SAGES. Today we're going to hear about the fundamental use of surgical energy. We have a great faculty. We're going to hear about the fundamentals of electrosurgery, fire in the operating room, monopolar and bipolar devices, ultrasound devices, and implantable cardiac devices. This FUSE program has been put together by SAGES and it contains much more information that you will hear in this 1 hour, but I hope it will give you sort of a taste of where some of the gap in knowledge is for most of us surgeons when it comes down to using energy devices. Before we get started, a couple of housekeeping points. You see this white chat pod on the left side of the screen. You can put in your questions, and we will discuss those at the end of the webinar at the panel. Should you lose any of the connections, just get out of the webinar, close your browser, and launch the program again. If you have persistent problems with that, you might have to restart your computer. At the end of the webinar, there will be a link to a SAGES survey. We encourage you very much to take that survey. It will give us an opportunity to get to know you and make some changes for upcoming events. This webinar is recorded, and in the coming weeks you will be able to see it online at www.sages.org. I'd like to remind you that next year, April 11 to 14, there's the World Meeting of SAGES and CAGS, the Canadian Society, for the 16th World Congress on Endoscopic Surgery. You're all invited. We'd like you to come. It's in Seattle, Washington. Visit the SAGES website for more information. And don't forget to join SAGES if you haven't joined it yet. So to start, I would like to give you a brief introduction why FUSE might be important for you. So I have no disclosures. This is a case that made big waves in approximately 7 years ago. This beautiful young lady on the left underwent a small skin operation of her face, and this is what she looked like after the operation. These things happen. You might not have ever seen one of these, but if you stay long enough in business, you probably will see one of those cases. There's hundreds of them every year in the United States. And they have to do with everything we are teaching tonight, trying to prevent those types of injuries. This is another case where a gynecologic operation led to a burn of the colon. This is the same patient on the left and the right. On the left, you see the initial injury, and 15 operations later, you see the results on the right. There's 2 million laparoscopic cases per year done in the U.S., and it's estimated that 1 to 2 per 1,000 have electrosurgical injuries of that nature. So you can do the math. That is not a small number. Not here, not me, no way. That's how we think about it when we see these pictures. This could never happen to me. Yet, this child had an injury from a dispersive electrode burn, third-degree burns with, as you can see, affecting his joint and probably with lifelong sequelae. Here's another case. A famous senator who had just routine gallbladder surgery and came back to the ER within a week with sepsis and died. Unintended, non-recognized injury of the small bowel with an energy device. Also a completely preventable injury. This is a young kid, 17 years old, morbidly obese, underwent a Nissen fundoplication for GERD and died from a perforation of the stomach that was unrecognized. And you can see the burn marks, the classic for surgical energy burn marks, with complete necrosis of the gastric wall, leakage that was unrecognized, treated too late, and led to the demise of the patient. Now, you don't always have to have a hole in the, and we'll explain this during the webinar. Here are injuries that have not led to perforation in a case that had a perforation, and several other areas of the small bowel were found to have burn injuries, as you can see. These injuries are not rare, and they don't have a small mortality rate. This is a paper which looked over 300,000 laparoscopic procedures, and the overall bowel injury rate was almost 1%. The unrecognized bowel injury rate was 1 in 3, and the overall mortality for bowel injury was 3%. That, when you think about a colon resection nationally is 2%, that's a pretty high number, and if it's unrecognized, it's almost 8%. And 1/3 of all these bowel injuries are related to the use of electrosurgical energy devices. This is a study in France where surgeons across the country voluntarily reported cases, 614 cases in 2 years related to fires, insulation failure, skin burns, visceral injury. Almost 90% of the surgeons had seen these injuries. And they led to 150, almost 150 unplanned reoperations. That's 70% of the cases. And you can see they're related to all the different energy devices we use. They're not related to one particular energy device. This is an email from the system I work in Kaiser, where the chief of cardiothoracic surgery relates to recent flame-ups in the OR and fires related to electrocautery usage and surgical sponges. And he doesn't understand why it's working, which is already a very good first recognition that we don't really understand sometimes why these things work, because we don't have the knowledge. And he wants everybody to take the FUSE course to try to make sure that his staff understands why these injuries occur and thereby get the ability to prevent them. So why FUSE? Hundreds of OR fires in the U.S. annually, estimated 40,000 patients burned by faulty ES devices every year. Up to 70% of the burns are undetected, which leads to the high morbidity and mortality rate. Only very few people are experienced and understand these injuries, and the vast majority, over half of them, know somebody who had an injury. And importantly, almost more than $500 million paid in 1999 for claims. You can imagine what the number would look like today. So let's face it. Would you go under the knife if you knew your surgeon had not been trained in the devices used in your surgery? Your answer is likely to be no. Yet every day we go under the knife and don't know if our surgeon has been trained or not, because there hasn't been any training program until FUSE. FUSE is a two-part training program. There's a free online curriculum, and we'll tell you how to get on it, and a FUSE manual for those that still like to get their knowledge from books. And at the end of all this, we encourage you very much to get FUSE certified. This year, for all SAGES members, the test is free of charge. It can be, you can have a test done at one of the multiple test centers around the country, or at the upcoming ACS meeting, or next year at the SAGES meeting. We encourage you all very much to consider to become FUSE certified. Once you are, you can be the champion in your institution to spread the knowledge that we think is fundamental for you to be a safe surgeon. So that's my introduction to FUSE today. I will introduce the next speaker, Dr. Amin Madani. Dr. Amin Madani is from the Department of Surgery at McGill University in Montreal, and he will talk today about fundamentals of electrosurgery. Dr. Madani.
Thank you, Dr. Fuschiber. Good evening, everyone. As I load my slides. All right, here we go. So we're going to start off this really great session tonight by talking about the fundamentals of electrosurgery. You know, the point of this is not really to focus so much on the basic physics and the mathematics, really to keep this as practical as possible. Only by understanding the very fundamentals of the energy devices that we use every day in the OR, only then are we going to be able to troubleshoot when things don't work in the operating room in the middle of the night. By understanding the fundamentals, only then are we going to be able to prevent adverse events from happening, like OR fires, for instance, which we're going to talk about later on. So we're going to try to just give you a broad overview of how this type of energy works. There's different types of energy that you can use in the operating room, and we'll talk about all these different things, but radio frequency is really the most common thing, okay? Radio frequency is anything from monopolar devices, bipolar devices, RFA that's used by radiologists. In the endoscopy suite, you use radio frequency energy. So it's really the most common and the most important energy device to know about. But and we'll talk about later on different energy devices, but we'll focus on the fundamentals of RF energy for now. By the way, I have no disclosures with this presentation. So how does RF electrosurgery work? In a nutshell, what it is it's the conversion of electromagnetic energy, okay, turns it into alternating current, which then converts it into kinetic energy of all the ions inside the cell, okay, which then ends up oscillating really quickly. And then that kinetic energy is then turned into thermal energy, which raises the temperature of the cell. And then we see this as a tissue effect when we operate. Okay, so it can be anything from tissues vaporizing, being desiccated. We see a coagulation of tissues and also fulguration. Okay, so none of this is cautery, okay? RF electrosurgery is distinct from that. So let's demonstrate that a little bit closer. So as you press the button on your Bovie, you activate it, you start getting a buzzing sound. Basically what it does is you apply an alternating current, okay, across the cells. So there's a positive and negative charge across the cells, and all the negatives inside the cell go towards the positive polarity, and all the positive ions inside the cell go towards the negative. But because it's alternating current, this thing oscillates really quickly, as demonstrated in this animation. And because it oscillates really quickly like that, you get frictional forces. There's a lot of friction with the big negative charge proteins in the cell. And that friction is what raises the temperature of the cell and then ends up manifesting itself into the different tissue effects that we're going to talk about later on. So this is really in a nutshell what RF electrosurgery is. So what happens when you raise the temperature of a cell? Okay, we all start off at 37 degrees Celsius. And then, okay, let's say we go to 50 to 60 degrees Celsius. And I apologize to my American colleagues who use Fahrenheit. I don't have the conversion off by heart, but we'll use the Canadian version for now. So 50 to 60 degrees Celsius, you get cell death occurring over a few minutes, from 1 to 6 minutes or so. The cell membrane starts to break down, the cell starts to dehydrate, and the cell dies. What happens when you go higher than that, 60 to 90 degrees Celsius? This is an important range, and we'll come back to talk about this range later on. But essentially what happens is the cell, two things happen. Number one, the cell membrane breaks down, the cell dehydrates, and it starts to shrink, okay? The second thing that happens is because you're raising the temperature, the proteins inside the cells start to denature, okay? So it denatures, but then when it cools down, it reforms, but in a haphazard manner, not in their original shape. And so you got this sort of coagulum that forms, okay, as the cell dies. And we can go even higher than that. We can go above 100 degrees Celsius. Above 100 degrees Celsius, what happens to water? It boils. So the cell literally vaporizes and blows up into a steam of a vapor and ion. And so this is called vaporization of the cell. And this is what you see as tissues being cut, literally cut. It's cells being vaporized. And we can go even higher than 100 degrees. We can go to 400, 600 degrees Celsius. And when you go to really high temperatures, you actually go so high that you break down the organic material into its elemental carbon. Okay, so that's why sometimes when you use high voltages and high energies, you get this sort of black hue that forms on the tissue, kind of like soot. Well, that's because you've broken down the organic material into carbon. And the same thing, when you break it down into elemental sugars with high temperatures, you get sort of the sticky stuff that looks like, that has a texture of caramel. It becomes very sticky. So that's what happens when it becomes a very high temperature, and that's called caramelization. So to demonstrate that again, 60 to 95 degrees Celsius, you get tissue desiccation. The cell membrane breaks down, water evaporates, and the cell begins to shrink. Similarly, you get denaturation of the proteins, and then when it cools down, it reforms, but in a haphazard manner, so not in their original shape. And so you get this sort of white coagulum that forms, and this is called desiccation and coagulation, okay, in the 60 to 95 degrees Celsius range. So what is cautery? You notice so far we haven't actually said the word cautery, and we hear it all the time. You know, you hear it in dictations, pass me the electrocautery, but we don't actually use cautery. What is cautery? Cautery is the passive transfer of heat. So if I took my finger and put a flame on it, I'm using cautery. Or like if you took a branding iron or a hot poker to try to cause coagulation of tissues, that's cautery. Okay, so we don't actually use cautery when we use electrosurgery, which is very different. Now, that's not to say that we never use cautery. There are actually energy devices that use true cautery, but most of the time you're going to end up using RF electrosurgery. And there's a big distinction between the two of them. So what is an electrosurgical unit? We have this big device that sits in a corner. It has all these knobs and numbers on it. But what does it actually do? So for starters, it's called a generator, an electrosurgical unit. And it does three things. Number one, it converts the frequency from the wall output, okay, to a much higher frequency, radio frequency output. Okay, the reason behind that is because you notice how when you activate the device on your patient, the patient doesn't get electrocuted. They don't go into cardiac arrest. Well, the reason behind that is because you have increased the RF output to a high frequency to a point where the muscles and the nerves don't depolarize when you activate the device. Okay, so it surpasses the ability of muscles and the nerves to depolarize, and therefore you prevent them from being electrocuted. So that's the first thing. Second thing is, when you ask somebody to change the number on the device to, say, put it on cut 30 or coag 30, you're actually asking them to change the power, okay, the amount of energy per unit time, joules per second. Okay, so in this case, you're asking them to put it to 30. That's the amount of energy per unit time. And notice, the important thing here is cut and coag, both of them are 30. They're delivering the same amount of energy per unit time. Okay, there's no difference between their power here. Okay, so what is the difference between cut and coag? And we're going to spend a little bit of time talking about that. But that's the third thing an ESU does. It gives you, it allows you to change something called the duty cycle. The duty cycle is what distinguishes cut versus coag. The duty cycle is the percentage of time that current is actually going through your circuit. And that's what distinguishes these two functions. And we're going to illustrate that in my next slide. So just to, again, demonstrate, the wall output is 60 hertz, and electrosurgery is about 500,000 hertz. Okay, so you've bypassed the ability of muscles and nerves to be stimulated. So in that case, you don't electrocute the patient. Instead, you're enabled to deliver very controllable and predictable tissue effects when you activate the device. So what's cut? Okay, here we have a ESU in blue, and in orange, I've shown you what's called an oscilloscope. An oscilloscope just shows the amount of energy and current that goes through a circuit, okay? It's just going to demonstrate what the difference between cut and coag is. So we asked the assistant, the float nurse, to put it on cut and put it on 30, okay? And then we activate the device. This is what happens. This is the current that goes through the circuit. So first of all, it's a sine wave because it's alternating current. So you have alternating positive and negative polarities. But the important thing here is 100% of the time, you have current that goes through the circuit. It doesn't stop at any point. There's always current flowing through the circuit. And because of that, all that 30 joules per second, all that power is spread out through time. Okay, that 30 joules per second is delivered, but it's sort of spread thinly. And because of that, the amplitude or the voltage is going to be low. So cut delivers a continuous waveform, but with low voltage. Okay. Now, let's say we ask them to put it on cut 100, so higher power. You're going to get the same waveform, so 100% duty cycle. So 100% of the time, current is going through the circuit, but more voltage, okay, because you've increased the power. So you're going to have a higher amount of energy because of that. And if we go back to 30, we get the same waveform, but lower energy. So cut waveform is continuous, and it's relatively low voltage. How does this contrast to coag? Coag, so let's say we tell them to put it on 30. So again, same amount of power, okay, per unit time, but then when we activate it, this is what happens. So the duty cycle here is a lot lower. Instead of delivering current 100% of the time, it only delivers it 6% of the time. Okay, so a small fraction of the time. So instead, that 30 joules per second of power is now concentrated in these intermittent bursts of high voltage energy, current. Okay, so you have the same power, but it's now delivered in these intermittent bursts, but very high voltage. Okay, 100% duty cycle compared to cut, which was 100, but higher voltage. And this is important. You know, who cares about duty cycle in real life? But what's really important here is, you know, there's implications, because when you have a higher voltage from coag, it can have a variety of effects. You can have more thermal effect, more collateral thermal injuries. It can increase your propensity for OR fires and interference with implantable devices like pacemakers. So this has implications, and my colleagues are going to speak about that a little bit more later on. And what about blend? So blend, we often see this function on the ESUs. It's very similar, but essentially what it is, it's a spectrum. So if we put blend on 30, same amount of power again, and we deliver the current, now it's about 50% of the time. So it's basically a spectrum. On one end of the spectrum, you have cut, which is 100% duty cycle, and on the other end of the spectrum, you have coag, which is 6% duty cycle. But you also have settings that are in between if you want to customize for things intraoperatively. So in this case, you have a 50% duty cycle. Or you can have different duty cycles, so 66% or 83%. And that depends on the manufacturer and the different blend settings. Okay, and if you go to cut, you eventually have the lowest voltage. Okay, and if you go to coag again, you have the highest voltage. Okay, I hope that clarifies some of the differences between cut and coag. So just, I'm not going to talk about this too much because our next figure is going to talk about monopolar and bipolar energy devices, but essentially all radiofrequency electrosurgery is bipolar energy. And what you have is, it just depends on what you do with your different electrodes. So you have your active electrode, which is your handheld tip, and then you have the pad that sticks on the patient, and then you have your circuit that goes round and round, okay? And then bipolar instruments is the same thing, but you have two active electrodes in the instrument, okay? And so that's how you use radiofrequency electrosurgery. And remember, this is alternating current, okay? And notice the patient is never grounded, okay? This is actually a common misnomer. We don't use grounding electrodes anymore. They used to be used several decades ago, because it increases your rate of injuries, and my colleagues will talk about that later on. So this is an important slide, especially for those of you who want to write the FUSE exam, and also practically speaking as well. So how do you modulate the thermal effect that you get? We already talked about how you can use cut, coag, different power settings. but you can also do that without even touching the ESU. So the thermal effect, there's three main factors that affect how much heat you generate, okay? There's this thing called current density, okay, which we'll talk about in a second, which is really the most important one, the one with the most effect. You have a resistance of the tissues, so you know how fatty the tissue is or how much water content there is. Has anybody ever tried activating in a pool of blood? You'll notice that it doesn't really work very well. That's because the blood is a conductor, and so that current is spread and doesn't have very much of a tissue effect. So resistance is has a big effect on how much thermal effect you get. The other thing is how much time you activate it. So obviously the longer you activate your device, the more thermal effect you get. Now this other thing is called current density, and I'm just going to talk about this a little bit. Current density is the amount of current that goes through your circuit divided by the surface area with which you make contact with the tissues. So imagine this. So imagine you have your monopolar device. You can either buzz using the tip here, okay, the very tip, or you can put the flat part. Okay, so the tip is going to be very low surface area. And because it's low surface area, the density is going to be very high. On the other hand, the flat part is going to be very lower current density, and therefore it's it's going to be very high surface area but lower current density. And how does that change things in the operating room for you? So this video really shows it nicely. So in this case, they're going to use the flat part of the electrode, and it's going to be lower current density. So it's going to raise the temperature of the cells to the 60, 95 degrees Celsius range, enough to desiccate the tissue. Okay, it hasn't vaporized it yet because it's lower current density. But when you start using the tip, okay, all of a sudden the thermal effect is higher. Okay, and because the thermal effect is higher, it raises it to above 100 degrees Celsius, where you also get vaporization and more of a cutting effect. So there's a difference in how you use your electrode in the operating room, and you don't necessarily have to crank up to put it on coax 50 so you can get more of a cutting effect. So you can actually use your electrode smartly without increasing the energy to get, in order to get the tissue effect that you want. So what kind of tissue effects can we get? We can get vaporization of cells. Okay, so this is what cutting looks like. You vaporize. You can get desiccation and coagulation, and something called fulguration. And we'll talk about each of these ones individually. So let's talk about cutting, vaporization. So the first thing I'm going to mention is one of the common confusions is on the monopolar Bovie pen, you have a button that says cut. And the misconception is that by pressing cut, that's how you cut tissue. But in fact, we do a lot of dissection using coax. So what's the difference between the two? So here on the left, I have a diagram where here is the tissue. And I'm just going to get a pen here to show you. So you touch the electrode. You're touching this area here. You're going to raise the cellular temperature to above 100 degrees Celsius, and it's going to vaporize the tissue, and you get a cutting effect. But because it's low voltage, the cut gets low voltage, it's lower energy, and this surrounding tissue does not experience a high rise in temperature. Okay, so you don't desiccate this tissue very much. It still stays healthy, okay? When you contrast this to this one over here, which you use coax, so a high voltage, yes, you touch these tissues here, you raise the temperature, and it goes above 100 degrees Celsius, and you cut the tissue. However, because it's high voltage, this surrounding tissue here, okay, also experiences a rise in temperature, okay? It may not be more than 100 degrees Celsius to cut it, but it will be in the 50 to 95 degrees Celsius range where it's enough to desiccate the tissue. And so you get sort of this coagulum that forms as well, okay? And this is sort of demonstrated here. You have cut on one hand, minimal desiccation of tissue, and over here you have coag where, yeah, you cut tissue, but you also desiccate a surrounding tissue. So you get collateral thermal spread. Now, does this mean the answer is use cut all the time? Well, no, not really. Cut is good if you're cutting skin, for instance. You don't get a lot of desiccation, so the tissue is healthy. and this, you're going to get good wound healing. But, or the other one that's really good is if you're cutting and you're dissecting and there's a very important structure in here, like a common bile duct, where you don't want to use high voltage, this would be a good function to use, or like a nerve or blood vessel or something. In contrast, coag would be good if you have, let's say you're dissecting through muscle and you want all those small bleeders to coagulate. So this would be, you want that collateral thermal spread because it's beneficial. So this would be beneficial for those settings. So the answer here is to just use cut and coag smartly and cater it to what you want to do in the operating room. And as demonstrated here, they're using a cut waveform, and you can see there's very minimal collateral thermal spread. You can do this for hemicolectomies if you're in an avascular plane. You don't necessarily need to use coag. It can increase your rates of injuries and collateral thermal injuries. A lot of bile duct injuries are caused because of that as well. So what about desiccation and coagulation? We already talked about that, but I'm just going to mention one other important thing. So it's a very common situation where you have a bleeder in the operating room, you pick it up with a forceps, and then somebody says, buzz me. Now, I'm willing to bet most of the participants who are listening, when you're buzzing somebody who's picking up a bleeding vessel, you're going to use coag. That's what most people do. That's how I was taught as well. However, the best way to do that is called, by the way, this is called coactive coagulation. The best way to do that is to use a low voltage waveform like cut. Why is that? Let's demonstrate that with the schematic here. So here we have the dispersive electrode, and here we have the active electrode, and this is the tissue. And then we activate. Okay, let's say we're using coag. Okay, so interrupted waveform, high voltage. We start activating. You start getting a lot of desiccated tissue here superficially. Okay, but the problem is this desiccated tissue is an insulator. It's not a conductor anymore. So this tissue beneath will not get any thermal effect. There won't be any tissue effect there. So what you end up having is a heterogeneous area of desiccation. Okay, it's not a homogeneous vessel seal anymore when you're on your pickup. It's kind of like throwing a steak into a very hot pan with a very high temperature. The surface is going to burn, but the inside is not going to cook very much. In contrast, when you use cut, you activate it, it's going to slowly cook the full thickness of that tissue. And so you end up getting this homogeneous vessel seal. Sure, it takes a little bit longer for this seal to form because it's lower energy, but it does a much better job. It's more homogeneous, and it seals the vessel better. So low voltage, slow, but much more homogeneous, a nice seal. And coag, you get something very heterogeneous, and it doesn't seal the vessel very well. Now, for very small bleeders, you're not going to notice very much of an effect. They're both going to be probably the same thing. But when you have bigger vessels, this becomes important. The other thing is, remember when I mentioned you get caramelization when you raise the temperature so high? Well, that caramelization makes the tips very sticky. And so when you let go of your forceps, you actually release the seal. And so it can undo the seal, and you can get a suboptimal sealing effect. And what's actually important, if you notice the instruments that are like advanced bipolar sealing devices, like the ligature and things like that, they're designed for hemostasis when you activate it. And they actually use a continuous low voltage waveform. So imagine that. You have a low voltage waveform designed for vessel sealing. So that tells you that this is the better way. So I hope I convinced everybody next time. So fulguration, this is the last thing I'm going to talk about. Fulguration is basically when you spray current. Essentially, it's a no-touch technique. So you bring the electrode close to the tissue, you activate it. Because it's very high voltage, the energy jumps across, it arcs, and it superficially desiccates the tissue, okay? So just like I previously showed you, it doesn't transmit energy to the tissue below, it spares that, but you get a very superficial area of desiccation, okay, because it's a non-conductor. It doesn't travel below that once it's desiccated. And this is really good for situations when you have raw surfaces that are bleeding. So again, high voltage modulated current, no touch technique, and it's usually better when you have a larger surface area electrode to do this. And the good thing about this is, like I said, if you have like liver or spleen, you want minimal penetration, you really want to coagulate a raw surface that's bleeding, and then this is really good and a good technique to use. And in fact, argon beam plasma coagulation actually uses this form of energy, this form of tissue effect by fulgurating the tissue. So I'm going to leave it at that. Okay, this was really like a broad summary of the basics of electrosurgery, and these are really the high-yield topics for those of you who are planning to write the FUSE exam. And I am happy to pass it on to the next presenter.
Dr. Madani, that was wonderful. I think it's a very big topic. The usual presentation when we do these at meetings or when you go to the FUSE curriculum, it's a 1 hour or 35 minutes presentation, and Dr. Madani did a great job to just pick out the most important things that we all need to know, and it's counterintuitive, as you can tell. So for most surgeons that have never heard about this, they say, why have I been doing coag for all my life when now I'm being told not to do that? And that's because there has never been a real interest to teach surgeons how these things work. And all the teaching has been done basically by industry, which is haphazard. And so we are here today to show you that now you have a curriculum, a learning curriculum that actually addresses these gaps. I'm going to proceed with the interesting stuff, the fires, the sparks, the flames. I'm going to talk to you about ore fires and burns. So we're going from explaining how it works to what can happen if it goes wrong. So I entitled this part Operating Room Fires and Burns. I have no conflicts for this one either. You saw this already. This is a classic skin burn from a dispersive electrode that was malfunctioning, not attached, and there were high areas of small areas instead of large areas, and energy concentrated and led to third-degree skin burns. We showed you this already. This is a repetition, but just so you can see to what extent these things can happen. Now, I'm going to show you a video from the Nick television series. This is a video that represents 1928, when the first energy devices were used that were based on electrosurgery and radiofrequency ablation, radiofrequency current. And this is a very good realistic representation of what can happen in the operating room when you use these devices. And these things happened the moment these devices were introduced in the operating room by Bovey himself, when the first machines were placed in the operating room about 100 years ago. Let's play that video.
Dr. Chickering will now cauterize the end of the duct.
This is actually a true museum piece device that they used for this film.
Make toast. Very good.
Oh. Get it off! Get it off!
Burn it! Burn it! No self-concealing.
Respond! Don't!
All right, just so you know, in 1975 was the last nurse that was electrocuted in the United States. So it took 50 years from this video, and still people died of electroshocks in the operating room. We don't see that anymore because now we don't have ground devices. Dr. Madani alluded to that. But all the other aspects that you saw, the fires, the burns, That still happens today. That's 100 years after the introduction of this technology. So it's estimated that several hundred cases per year happen in the United States alone. Most are minor and result in no injury, but 20 to 30 per year, as you have seen on the pictures that I've shown you, are disastrous, and some lead to death. So this is not something you should take lightly, especially when you think that these are 100% preventable. So the data that we have are from regional databases. Here's just to give you an example, the Pennsylvania Healthcare Coast Containment Council data, and they calculated that over 10 years, 1 in 200,000 OR cases result in a fire. Again, we are doing millions and millions of cases in the United States, so multiply that. I'm going to show you a typical case report. Usually it's a minofacial surgery, alcohol-based preps, O2 by nasal prongs, full closed drape, and a spark was observed in the field, and a flash beneath the drapes. The surgeon might not see much of a flame, especially if it's alcohol-based. It's a blue flame. Most of the injury occurs underneath the drapes. And I've shown you this example. There's many others of people that have been burned by fire. And when you look at the left lower little insert, 15-day-old boy dies in flash fire in the operating room. So these injuries not only lead to burn, but they lead also to death. The ASA closed claims study showed that out of over 100 claims for OR fires, 90% were due to electrosurgical devices. 85% occur in the upper area of the body. 4% use open oxygen as a source, and 20% lead to permanent disability and death. A couple of misconceptions that are out there. Drapes are treated to be fire retardant. Yes and no. They are not fire retardant. Or they may be treated, but they burn, and I'll show you that in a minute. They burn just very well when there's a fire. Betadine skin prep is flammable. No, it's not. It's the alcohol that we add to the betadine or the Hibiclens that we use that causes the fires. And when there's a fire, should you get a fire extinguisher first? The answer is no, and I'll explain to you a little bit later what you do and how you do it when a fire occurs. And no, lanugo hair is not flammable in air. So when we talk about OR fires, we talk about the three things that lead to it, and that's fuel, oxidizer, and an ignition source. Obviously, you have to have those three things for a fire to happen. And let's play this video here. This is just to show you that you can actually burn iron in oxygen. This is a steel wool pad that's being heated up and placed into a beacon with oxygen, and you can see that the steel completely disappears, gets burned into iron oxide. So if you have oxygen in your environment, everything burns. Pretty much everything burns. The next video shows you some experiments the British did for their fighter pilots that in high altitude are under. And you can see that under 100% oxygen, how fast a fighter suit burns. And think about the patient in the operating room under the drapes. That's how fast those drapes will burn. So what do you do to prevent these things? First of all, you minimize the use of open O2. So you use a mask or a cannula or LMA. And the key is to keep the oxygen concentration below 30% for those cases. Don't go above 30%. And obviously, if you do anything around the neck, and especially around the trachea, use cold instruments. The intubation tube, the tracheostomy tube, becomes a flamethrower, as you can see on that picture, where fire is tracking back up the ET tube and the flame goes and the smoke goes into the lung, and that's where the lethal injuries occur. And that has consequences of, again, what you're going to do when a fire occurs. And it's going to be, some of it is going to be counterintuitive, but you have to do it to avoid injuries that are lethal to the patient. Fuel, well, as I said earlier, almost anything will burn with O2. So in principle, everything that's in the operating room lying on the patient essentially is a fuel source. But beware especially of alcohol. Make sure it's dry. And remember that alcohol flames are very hard to see. And igniters, well, we have a lot of them. Light sources, the energy devices we use remain hot, and somebody could accidentally, as you have seen many times in the operating room, activate a device when it's not being supposed to be used and cause a fire that way or a burn. The key is avoid ignition when using electrosurgical devices. So again, in open oxygen situation, you have to have everybody on board and understand that that's a high-risk situation. When you have a monopolar device, wait till you can see where the tip is before you activate it. That's especially important in laparoscopic cases. Make sure the tip touches the tissue so you don't have arcing, which is a perfect way to start a fire, and deactivate the unit before the tip leaves the surgical site. Place the electrosurgical device in a holster, so don't place it on the field somewhere. It will burn through the drapes. And as shown on the picture here, and I don't know if anybody still does that, but if you see somebody doing that, please don't learn that that's a good thing to do. It's not. Don't use any of these rubber sleeves. I'm going to show you this video. We're going to run this video. That's just to show you what it looks like when a fire occurs and what the optimal sequence of events is to deal with a fire in the operating room.
Fire! Fire! Get the oxygen off.
Pull the drapes down. Get some sponges and saline.
I'll get the extinguisher.
I'm concerned about an airway burn. I think I'm going to intubate the patient.
Okay.
So when you look at that and you say to yourself, would I be able to make this happen the way it's shown in the video? The answer probably is no. So it does require some training. And we do recommend that the hospitals and OR teams at least twice a year come together to train a situation like that, because it really is a choreographed dance to react. And as you can see, the most important thing is to disconnect any oxygen source with the patient. So don't be afraid to rip out the ET tube, even in a anesthetized patient that's intubated. That's probably one of the first things you should do, and remove the drapes. It's not so much about what you do first, but you need to do is all these steps very fast. And these steps are: stop the flow of airway gases to the patient, disconnect the breathing circuit from tube and remove the ET tube, and pour saline down the airway if you have a fire, if you suspect a fire at the end of the tube. Immediately remove all the burning materials from the patient, whether on or in the patient, and extinguish the fire on burning materials with the CO2 fire extinguisher. Ask yourself, do you know where your fire extinguisher is in your OR? And then, of course, care for the patient. Restore breathing, use room air, never O2, and manage the patient's injury. As I said earlier, they're 100% preventable. So the key to prevention is that the team does understand how to react and is aware of it, that you have communication before and during the procedure about the fire risk, especially if you do head and neck surgery or high-risk surgeries with lasers or other igniters, that you educate the entire OR staff on a regular basis what to do. And there's now, and I'm going to show you one of them, the most well-known risk assessment tools to check if the fire risk prior to do the surgery and I already mentioned the aura fire drills. So one of the common tools is the silver stain fire risk assessment. It was developed in Delaware at the Christiana Care system. And it's a very simple scoring tool. Is the surgical site above the xiphoid, you get 1 point. Open source oxygen, 1 point. Ignition source and use, 1 point. If you have 3 points, that's a high-risk patient. You need to really be careful. Anything below that, you just do your normal precautions. So it's straightforward and simple to use. I'm going to switch gears and talk about burns. Now, what's the difference between fire and burns? Fires are open flame situations in the operating room. Burns are much more insidious, and Dr. Madani already alluded to it. It's what can happen, and I alluded to it in my introduction. It's what can happen when you use an electrosurgical device and you have a thermal injury that you hardly can see or don't see or are not aware of, and it leads to full-thickness necrosis of the hollow viscous or a vessel, and then to complications of the patient. We believe today that a lot of the ER returns of patients that had undergone laparoscopic GI surgery, that a good percentage of them is probably due to inadvertent injuries that not necessarily need to full-thickness necrosis, but need to lead to abdominal pain syndrome, similar to what you get when you do an endoscopy and you have a thermal injury from a polypectomy and the patient comes back with abdominal pain. Even though there's no perforation, the patient comes back. It is thought that 40,000 patients per year are burned by the faulty use or faulty energy devices. As I said earlier, 70% undetected. A lot of people, very few people have experience, but a lot of people know of this problem, and financial implications are vast. I'm not going to repeat this, but there are cases to show. So I'm going to go right into the different mechanism by which accidents or burns can happen with those devices. The first one, and they all have to do with current diversion. In other words, you have your energy delivered where you don't want it to be delivered because of either faulty devices, or you are not using the correct device, or you are setting the power or the energy at a level or a type that's not appropriate for the procedure. So the first one is simple and straightforward: insulation failure. It is thought that it's rather common that insulation failure lead to burns in laparoscopic procedures and other procedures. It's the smaller breaks on the instrument's insulation that lead to the dangerous situation. And I go back to what Dr. Madani said about the density, current density. The smaller the break, the higher the leaking current density, the more energy per square inch or millimeter is delivered, and the higher the injury rate is. It's also important to understand that most of the breaks in the insulation are not visible to the naked eye. So in your hospital, there's hopefully somebody downstairs in packaging that tests the instruments after they've been autoclaved or before they get autoclaved if they have insulation breaks, and there are devices that can do that. But be aware that in some studies, up to 30% of the new instruments that come from industry already have insulation breaks. So with regard to insulation breaks, really the word should be, you have to assume every time you use a long-shafted insulated instrument in laparoscopy, you have to assume that this instrument has insulation breaks and use it accordingly. In other words, you need to understand where it is, what is it touching, and when the energy is being applied, that it doesn't touch anything you don't want to touch because there could be a break. Let's play this video. It's just a nice schematic video to show you what can happen. So you will see the activated device with the insulation breaks, and you can see how it is touching the metal video camera, and through the metal video camera, a burn occurs onto the bowel at a place that you're not even looking at. We can run the video one more time just for you to see it well. And this is so easy to happen. When you think about how small the area is that you work in when you do a laparoscopic surgery sometimes, and everything is touching everything, and you're not aware necessarily all the time of what's going on. This really should raise your awareness that it is important to keep track of this. Another current diversion is called direct coupling. That's also very simple and straightforward to understand. Happens all the time on purpose. It's how you apply energy to a simple forceps. It's by direct coupling. You touch the forceps, the energy is coupled from the energy device to the metal object that you're using. And this is good in most cases, but sometimes if you are not careful, the energy can be diverted to another device like the retractor that's shown on the left side, or when you are operating in a laparoscopic environment, you can accidentally touch a metal camera that is touching the bowel, and before you know it, you may never know there is energy transfer into places that you don't want energy to be transferred at. That's called direct coupling. One of the, we're going to run this video in a second. I'm going to show you this video, but first I'm going to tell you about a case that a couple of weeks ago, a colleague of mine told me he had a leak after a simple appendectomy. And I asked him, what did you use to divide the appendix? I used an endo-GI staple line. Okay, I said, great. Did you have any bleeding? He said, yes, I did have some bleeding. And I asked him, what did you do? And he did exactly what we're going to show you here in this video. And then you'll understand why this patient had a leak. So let's run that video.
Go. Yeah. Slow. Yeah. Good.
So what you see is somebody trying to control bleeding on a staple line with a monopolar device, probably using coag, which is very high voltage. And what you see, and we're going to run the video one more time for you to really see it, what you see is that the clip starts melting. And you can see flying debris, that's melted clips. Now, if you knew that these clips are made out of titanium, which you probably know, then I can tell you that the melting temperature for titanium is 1,000 degrees Celsius. It's such a small surface, the clip itself is so small that the current density, when you apply 4,000 volts with coag, is so high that you can reach temperatures of over 1,000 degrees. Now, you can guess what that does to the living tissue, and you can guess that if you do that long enough, that you will destroy and necrotize the staple line and that you might get a leak. And that's my assumption, what happened with this patient. And it will happen to you if you do that. So please don't do that. If you have a bleed on a staple line, either oversew it or hold some pressure and wait till it stops on its own, which most of these will do. This is the one current diversion that's a little bit more difficult to understand. It's called capacitive coupling. Basically, because we are using alternating high-frequency current in electrosurgical devices, every time you send high-frequency alternating current through an insulated electrical conductor, which is almost any laparoscopic device that you use, an electromagnetic field will build around that insulated device. And this electromagnetic field can jump to another insulated or non-insulated device, and the energy can be transferred simply by having those two instruments close together. They don't have to touch. And that's called capacitive coupling. So you have a stored electrical charge. That's a simple way to say you have an electromagnetic field. And when two conductors are separated by an insulator, the electromagnetic field induces a current in the nearby conductor, Key again, and this is the mantra of our FUSE program, key again is the higher the voltage, the higher the stronger the electromagnetic field, the higher the risk for capacitive discharge. Low voltage, low voltage, low voltage. Get rid of using coag and turn the ESU up to higher and higher numbers when you are in a problem with bleeding. Think of other ways to control that bleeding by instead of just going up on the voltage, because you're going to have a very high risk at that moment to have one of these injuries. Can we run that video? So here's another situation where you have an insulated device that's activated within a metal cannula. And you can see that the energy through the insulation jumps onto the metal cannula through the electromagnetic field, and the cannula causes the burn on the bowel. The same thing would happen if you have a hockey stick device that you activate, and you grasp the gallbladder with a grasper that's insulated, and you hold both parallel. When you activate the hockey stick device, the grasper will get energy, and as long as it's just a gallbladder, it's not dangerous. But if you hold some bowel away with that, it will have energy going to the tip of the grasper, to the metal tip, and go into the bowel wall. Another very common situation where you have capacitive coupling is when you do this, which is very common. I would venture that half the operating rooms I walk in today in the United States will have a situation like that. This is capacitive coupling. The energy that goes through the cord that's insulated jumps onto the clamp, and if the clamp for some reason touches the skin of the patient, there is a risk for burning the patient's skin. So you should never do that. You should really use the holster. The classic experiment for capacitive coupling is single-site surgery. Now, because in this situation, by design, the instruments are very close together and parallel, and that really increases the risk for inadvertent energy diversion, and as schematically shown here, an inadvertent burn to a hollow viscous organ. So the risk factors, I'm repeating myself, high voltage, so coagulation mode, small ports, open activation of energy devices, which means you don't wait till the device touches the tissue, you activate before, and the ESU automatically tries to overcome that resistance, which is the air, and jumps the voltage up. And then you get arcing and high voltage built up in the instrument before it discharges into the tissue. So don't do that. Always try to touch the tissue before you activate. The same effect essentially is when you activate over previously desiccated tissue. You have an insulator now. So the voltage goes up trying to overcome that resistance. And this is an example, as already alluded to by our previous speaker, where you have a common bowel duct injury clearly from a electrosurgical thermal injury. So when you do anything around the bile duct during a gallbladder, difficult gallbladder, use short bursts of activation, minimize the amount of energy you deposit into the tissue. When you do a laparoscopic cholecystectomy, start with 15 coag or 15 cut and go up to 20 if you need to, or 25. I can bet you that you can do almost every laparoscopic cholecystectomy with a setting of cutting not higher than 25. Don't start with 35 coag and then cut rather than coag. This is sort of a paradigm shift in terms of how we look at the use of energy devices that really would reduce your risk to have one of these injuries. Make your OR safe, get FUSE certified. And with that, I'll finish my talk. We go on with the program, and I'll invite Dr. Dean Mikami to talk about monopolar and bipolar devices. Dean is an associate professor of surgery and division chief general surgery at the John Burns School of Medicine, University of Hawaii. He has been with Fuse for many years and one of the most effective and productive co-workers for our team.
Okay, thank you very much. I'm in Honolulu, Hawaii right now, and I think much of you, it's probably dark outside. Right now it's only about 2 o'clock my time, and the surf's up and everything, so I'm going to try to put us back on time, and I think we're running about 20 minutes late, but I want to thank our previous speakers, Amin and Pascal, for doing much of the heavy work and the physics behind monopolar energy and everything. So what I really want to talk about are the practical things that you need to know in the OR. So we talked a lot about the physics of RF energy, so we're going to kind of dive into how we use this RF energy in the OR safely and effectively. So here are my disclosures. It shouldn't have anything to do with the lecture here. So basically, we talked about the modalities of RF energy. We talked about monopolar and the bipolar mechanisms that we use in surgery. So a monopolar is very simple to understand, right? You just have an active electrode. You know, in the Fuse group, we don't like to use the word bovie. Every time we use the word bovie, we have to pay like $1 in the jar. So we use active electrode. So in the OR here in Hawaii, when I'm training our residents, I'm like, okay, pass me the active electrode. And they're like, what is that? I said, no, it's the bovie, but we don't call it the bovie. We want to call it the active electrode. So you also have something called, you know, in the old terms, the grounding pad, but we don't call that the grounding pad also. We call it the return electrode. So basically what happens is the current wants to go from the active electrode at the surgical site that you're working at, and it wants to complete the circuit. So that's what you need to understand in monopolar surgery or monopolar energy that you're using for surgery. Your ESU or your electrosurgical unit wants to complete the circuit. It's not really looking for ground, but it's really looking to complete the circuit. So the active electrode is in your hand, your active electrode pencil, and the return electrode is on another site. So basically, current flows through the body between these two electrodes, and we use different settings, right? So Amin talked about the multiple settings that we used on our ESU, and basically, when we use coag mode, we use a very high voltage, 3,000 to 9,000 volts. And in the cut mode, we use a much lower voltage, 1,350 to 4,000. So the take-home message here in monopolar is we're trying to complete the circuit. You have your active electrode in your hand, and the active electrode is trying to complete the circuit by going to the return electrode. So Amin showed this prior, and it's very important. So I bet you out there, when you're attending a surgeon, or if you're the surgeon, you tell the circulating nurse in the room, set the bovie, right, to 50-50 blend 2 or something, or 30-30 blend 2. And when I was a resident, I was like, what does that mean? I had no idea. Before I joined the Fuse committee, I would, as an attending, I would say, set the bovie to 50-50 blend 2. I had no idea what that meant at all. So now, understanding how this works is when you hit the yellow part of the pencil, and I think most universally the yellow is the cut mode on your active electrode. The blue is the coag mode. So out there, I'm going to ask you a question. You don't have to answer it aloud, but when you hit the blend mode, are you hitting the cut or are you hitting the coag? So the question is, how do you activate the blend mode? And I'll give you a second to think about it. Is it the yellow button cut or is it the blue button coag? And the answer is, it's the yellow button cut. So when we think of blend, it's actually not a blend of cut and coag together. Initially, I thought blend meant that I'm using coag but in a cut fashion. It really isn't. So it's actually the opposite, right? We're using the cut mode, but we're alternating the cycle where in the cut mode we have an off cycle. Amin talked about the coag mode being 94% off and 6% on. So what really happens in this situation is the energy that is being used, let me go back one, sorry here. The energy that's being used in the coag mode actually will dry out the intracellular fluid, collapse the cell, forming the hemostatic properties of the coag mode, and then you get this kind of eschar form and everything. So when we use cut mode, what happens is the cells in the tissue actually will evaporate, and the intracellular fluid turns into steam and everything. So we're looking at these different forms, but once again, when you use the cut mode on your electrosurgical pencil, it is the blend mode is activated. So you really can't set the machine. When you set your machine up, your ESU, you're going to set 30 power on your cut, 30 power on your coag, but there's going to be a blend mode. So most pencils only have 2 buttons. So if you're setting it to a blend mode, when you hit the cut, the only effect you get is the blend mode. You don't get the pure cut mode. So that's an important clinical factor to remember. Okay, so we talked about this a lot. So this is very, very important. And for you, those that are going to take the FUSE exam in the future, you need to memorize the slide. So when you use, when you vaporize something, you're holding your pencil above the tissue, and you're vaporizing it when you use cut. And remember when I tell you, when you activate the active electrode in cut mode above the surface you're working on, you get these sparks that actually fly off the end of the active electrode. It finds the surface area, right? Remember I told you it's trying to complete the circuit. The active electrode and the current is trying to get to the dispersive electrode. So these sparks actually fly off the end of your pencil, vaporizing the tissue beneath it. And then when you use coag mode, the same thing happens. It's the same power setting, but you have a higher voltage, and you get a much higher voltage activating on the tissue. So what does this all mean? Okay, so the variable effects that impact tissue and impacts the effects that you get. So we know that waveform is very important. The cut waveform versus the coag waveform, right? With cut, we have a continuous waveform. Coag, we have 94% off, 6% on. Amin talked about manipulating the electrode, right? If you use the edge of the electrode, you're going to have a higher current concentration. You're going to have more current in a very small area, giving you a much higher tissue effect. The time that you hold the pencil or the button down affects what you see at the tissue level. And of course, the generators that you use. Another important thing is, what type of electrode are you using? Are you using a ball tip electrode? Are you using a flat tip electrode? For you plastic surgeons out there, you often use the needle tip electrode, right? The active needle tip electrode. And that's, if you think about it, you have the highest current concentration at that needle. So you want very little tissue damage, but you also want the tissue effect. So using that needle tip active electrode gives you tremendous current concentration at a very low voltage. And that's an important thing to remember. So also power setting, the numbers that you punch in your machine will affect your tissue and the amount of eschar formation that you have. All right. Okay, so just like I said here, right, in the blue here, you have your dispersive electrode. So for all your residents out there, when you go to the OR tomorrow and you go like, okay, the nurse is going to ask you, where should we put the grounding pad? And you say, wait a minute, it's not a grounding pad, it's our dispersive electrode. Our ESU wants to complete the circuit, so where should you put your electrode, right? Your dispersive electrode should be as close as to your operative site as possible. So if you're doing a right inguinal hernia, you probably should put that dispersive electrode on the right thigh, right? You want to find a nice flat surface. If there's hair on that, that's going to affect the current going to the dispersive electrode, so you want to shave that hair. If somebody has a implant, you want to stay away from metal, right, because the metal will conduct the current. If you're working, say you're doing a Nissen fundoplication and you want to use monopolar, and the patient has a pacemaker, there's actually Dr. Robertson's going to give you a whole lecture on pacemakers and everything, but you probably want to put your dispersive electrode as close to the working site as possible, but away from important structures like the pacemaker. So once again, dispersive electrode should be as close to your working area as possible. Nice flat surface. Avoid implants. Make sure that there's no fluid underneath the dispersive electrode. That's why it's very important when you prep. And if you're using an alcohol-based prep, right, if the alcohol gets on the dispersive electrode, right now I want you to understand that the dispersive electrode it can be an active electrode, right? If enough of the pad gets pulled off in older machines, that dispersive electrode could turn into an active electrode. The nice thing about technology today is that you can see on this pad, it's a split pad, right? It's got 50% on the left, or maybe 45% on the left, 45% on the right, and they're striped down the middle. So what that is for is the dispersive electrode and the ESU is trying to figure out how much current is coming back from the active electrode. And if I get 45% here and 45% there, the machine stays on. But if the pad starts to peel off and I get 45% here and only 10% here, then the machine will shut off. It's because we could, in the olden days before we had the split pad technology, if the pad started to come off or you got cleaning solution around the prep solution around the pad and it started to peel off, and you had a very small surface area of the dispersive electrode, that could turn into the active electrode. And Pascal showed some pictures of the child getting burned in the hip, and that's what happened, is the dispersive electrode started to peel off, and it's such a small surface area that it actually caused a large burn. So remember, there's really no difference between the dispersive electrode and the active electrode. It's just the surface area determines how much tissue effect you'll get. So once again, the key message here and what we want to try to repeat over and over, use the lowest power setting to achieve the desired surgical effect. So a lot of times we're talking about using cut. Actually, in laparoscopic cholecystectomy, you should never use coag. You should use the cut waveform to do your lap choles. But if you survey 1,000 surgeons, I bet you 995 surgeons say they always use cut. I know in my training, our attendings would say turn off the cut mode when you're doing a laparoscopic cholecystectomy, but the answer is you should use the cut mode. Once again, you can use that continuous cut mode waveform or a blend form to achieve your surgical effect. One of the big things that we see a lot of is the eschar that forms on our instrument. So to prevent eschar buildup, you really want to prevent eschar buildup because it increases the resistance and contributes to arcing, right? Because you know that the active electrode is sending current, giving you a tissue effect, going back to your return or your dispersive electrode. As that eschar builds up, the current's got to go around that, so you won't get the effect right at the tip where you're working with. If you have a lot of eschar, you'll get this big kind of ball effect of the energy going through that area that you're working on. The eschar can also ignite, causing a fire. You know, we still use these, but scratch pads actually create grooves in the stainless steel of the blades, which can actually contribute to eschar formation also. Probably the best practices is to use a coated electrode. So when you want to remove the eschar that builds up after you use the instrument, you can get a gauze and wipe it off, or wet gauze and wipe it off and everything. So this is probably one of the most important things that you'll hopefully will take away from this lecture is, why do ORT members sometimes get burned while holding hemostats, right? So Amin talked to you about the effect of the current coming out of the wall at 60 hertz and the ESU turning it into a radio frequency of about 500,000 hertz and everything. So we operate in this range, right? But still, why do surgical team members sometimes get shocked while holding a hemostat? A lot of times I hear, and I ask that question a lot to our students and everything, and they're like, yeah, because there's a hole in the glove. I'm like, no, there's no hole in the glove. It's most likely the hole in the glove was secondary to the trauma that you received through that shock you got. So basically this is the mechanism. So you're holding say a hemostat or something else, and you're coagulating or you're trying to coap a vessel. So if you're the resident and your chief resident goes, okay, I'm grabbing a vessel, use the active electrode and touch my instrument, and we're going to seal this vessel. So what happens is, at the tissue level, the area that you're working on actually desiccates, and then you have an increased rise in resistance, right, at the tissue level. So that when the resistance reaches a point where the path of least resistance now becomes the person holding the hemostat, the current will try to complete the circuit. And what happens is you're leaning on the patient and you're holding the hemostat, so then the current goes through your glove, creating a hole in your glove and shocking you. So things to avoid that or try to minimize that is, once again, use the lowest power setting possible. So when you're using that hemostat, you want to make sure, especially if you're the attending or the resident and your junior resident's about to activate the electrode onto your hemostat, you want to use the cut waveform, right? We talked about the voltage being in coag at 3,000 to 9,000 volts, whereas the cut is much lower, 1,350 to 4,000. So make sure you tell your person that's going to activate it, use the cut mode, number one. You want to try to avoid touching the patient, because if there's enough eschar building up in the end of your hemostat, the resistance is going to be so high there that the circuit's going to try to complete through your hand. So another thing you can do is, instead of just holding it, with 2 fingers, grab that hemostat with your full hand, so the surface area is much, much larger. So if you do get energy through your body, it won't actually burn a hole through your glove and everything. And probably the most important thing is, do not do open circuit activation or open air activation. And what I mean is, when you have your assistant, you tell your assistant, okay, hit the hemostat with your active electrode, they press the cut button or coag button, and it's already pressed before it touches the hemostat. So what happens now, right? Your ESU can't sense the current that's going through or the voltage yet. It needs the circuit to be completed so it can modulate the amount of energy. So when you do that, right, you're going to cause arcing or a vaporization effect if you're using cut, and the current will jump off the end of your active electrode to your hemostat, creating this very high energy level right off the bat, and that could cause you to burn yourself. So you want to touch the instrument first and then activate the active electrode, so you don't do open air activation. And that will definitely decrease the chance of you getting a hemostat burn during surgery. Okay, so now we're going to kind of move on to a bipolar energy or bipolar RF. So what is the difference? So both of them are actually bipolar energy, because in monopolar, in the monopolar mode, we have the active electrode. The patient is this yellow oval part, right? And we have the dispersive electrode, and the ESU is just trying to complete the circuit. So energy or current goes in, goes through the patient, you get your end tissue effect there, goes through the dispersive electrode back to the circuit. same thing with bipolar. Bipolar, you have the active electrode and the dispersed electrode actually right in the tips there, and you have your effect right between the jaws of the bipolar instrument. So in bipolar mode, the active and return electrodes are in the instrument itself. Current is confined to tissue between the electrodes, and it uses a low voltage kind of in the cut waveform to have its end effect on the tissue between that. So what do you need for bipolar devices? You need coaptation. So coaptation means we're going to actually depress the tissue, and the more coaptation we get, the better the tissue seal is. And we saw this before here. So you really want to coapt the tissue so you get a very good seal there. So once again, in the bipolar mode, we're using a cutting waveform. We have low voltage continuous current there. So most of the new advanced bipolar instruments and systems use a low voltage not continuous, but they use an intermittent current, and I'll discuss this in the next slide here. So once again, most units now you want high tissue compression. So when you close your bipolar instrument, you get a very low voltage and you get a pulse current. And what that pulse current does is the ESU of the bipolar machine is actually measuring change in resistance. So when it closes the jaws, it senses back thousands of times a second. It wants to sense what the resistance is, because we know that when we have a good seal, the resistance in the tissue that we're trying to seal goes up significantly, right? So it's looking for a delta change in resistance to complete the seal. And when it hits that delta change in resistance, then you hear those beeps on your machine. So what are some of the clinical things we have to be careful with bipolar? So basically, we talked about this the entire webinar. We know that cell death occurs at 60 degrees Celsius. So we want to make sure that we don't have anything around that's going to be burned. So this is a thermal image of a bipolar instrument, and these wires are actually 5 centimeters apart. So you see all the thermal injury or thermal damage that can occur even though you can't see it. So once again, there are multiple different advanced bipolar devices on the market. They all have their different mechanisms that they seal with. But most of the advanced bipolars kind of follow this pros and cons. So it doesn't require a dispersive electrode because the energy doesn't travel to the patient. That's good, right? So if you have a patient with a pacemaker or AICD, and you really need to use a bipolar or RF energy device versus an ultrasonic device, this is probably a good choice because the energy stays between the jaws and the tissue that you want to treat. It uses a low voltage cut waveform. Energy stays between the jaws, and it can seal up to 7 millimeter vessels. The cons are we do have thermal spread that we see with the advanced bipolar devices, 1 to 3 millimeters in size. You do have current leakage through the cord, so don't wrap your bipolar cords or your monopolar cords around hemostats and then place the hemostat over a pacemaker. That's going to affect that. And definitely a significant increase in cost compared to other monopolar instruments. So this is the mechanism I talked to you about, the advanced bipolar units now. So it has a near real-time impedance feedback or resistance feedback from the tip. You get this pulsing rapid on and off energy that's being sent out. It allows for interval tissue cooling, and you get an audible signal that indicates an adequate seal. So basically a change or a delta change in resistance, and it has your beep. So a lot of times I get asked this question. So why is it when I place my bipolar instrument on a vessel and I seal it, I hear the beep, and I get a change in resistance? I go, that's correct. But why is it when I put it on again, it doesn't go instantaneously to the beep? It takes a few seconds again, right? And you think about it, you go, yeah, it should really like seal again because the vessel's sealed. And the answer is it's seeking a change in resistance. So if you start there and the ohms is, say, 50, and by the time you fire your first cycle, it goes up to 400. And then you put it on again, but now you know the resistance is 400 at tissue level. It's trying to reach 800, right? So it's going to really try to seal down more. So if you're really worried about large vessels and you want to do a double seal, you shouldn't put it on the same area. You should move off that tissue a little bit, or that vessel just a little bit to the left or right, and then seal it at multiple spots if you want multiple seals. So best practices, you really want coaptation, but you don't want to really pull up on it too hard. You want the bipolar energy device to do its job. You really want to keep the jaws clean, right? Because it's your active and your dispersive electrode in one instrument. You want to make sure that the eschars are wiped off, and you have to be very careful. It can seal up to 7 millimeter vessels, but if you have calcification, that may affect your seal. So here's myself here. So you can look at, this is the apparatus we set up here. We're using a FLIR thermal camera, and this is in Fahrenheit, not Celsius, but you can see that using a bipolar device, you really can't see it on the tissue. This is my co-worker's lunch that we took out of his fridge and said, sorry, this is sacrifice for science here. So we got his ham sandwich and we started slicing the ham down the middle. But you can see, even though this cold ham sandwich, as we use the bipolar device, it creates some thermal spread here on the side of it. So this is one of my last slides. So basically, what is the difference between monopolar and advanced bipolar devices? I think our next speaker is going to talk about ultrasonic, but basically we get thermal spread with both instruments. You can do direct coupling, right? You use the hemostat and use your active electrode on it. That's direct coupling to seal vessels. You can't do that with the advanced bipolar. Capacitive coupling is seen with monopolar and usually not seen with advanced bipolar devices. You get alternate site injury with the monopolar. With both instruments, you can get inadvertent activation. You mistakenly hit the pencil when you don't want to, or you step on the foot pedal. You get direct thermal extension more with monopolar devices, and both you can see current leakage. So in conclusion, I think it's very important for everybody to understand the fundamentals of surgical energy. If you're operating in the OR, you need to choose the right energy tool for the task at hand. And most importantly, as we said over and over, tissue death occurs at 60 degrees Celsius. You need to allow time for your active energy source to cool down. Thank you very much for your time and attention.
Thank you very much, Dean. We'll already had a question here. Will there be any talk about ultrasonic energy sources? And yes, there will be, and it's going to be the next talk. I'll invite Dr. Jasa Orlovsky, who is a general and MIS flex endosurgeon at Mount Auburn Hospital, Harvard Medical School in Boston. Jasa is one of the co-chairs of the FUSE committee, and she's been with us working to spread the word for the last few years. Jasa, please.
Hello. I'm Jasa Orlovsky, as Pascal just said, and I'll be talking about ultrasonic energy. I'll try to go a little fast to make up some time and to get Dean on the waves. I have nothing to disclose, and a disclaimer, if you do see any images of commercially available devices, that does not apply any endorsement of one company over another. It's just for illustration. So ultrasound energy is a type of mechanical wave energy. And by definition, this is energy that's transported through material via motion or disturbance of the material, such as vibration or oscillation. The ultrasound specifically refers to sound waves that have a wave frequency above the upper limit of human hearing, as you can see in this picture here. So it's greater than 20,000 hertz. And perhaps the best known use of ultrasound is for diagnostic imaging, where the wave frequencies are ranging from 2 to 18 megahertz. But the devices that I'll be talking about today are the ultrasonic shears that range from about 23,000 hertz to 55,000 hertz. So the reason why these devices are used, the first one, there's no electrical circuit needed. So this has a lot of advantages. You've already heard about dispersive electrodes and some of the pitfalls. So with the ultrasound energy devices, you don't need any dispersive electrodes. Similarly, since the energy is not going through the patient, there's no issue with stray electrical injury. And there's also no interference to monitors. So if you have a patient who has a pacemaker that they're dependent on, if they're having EEG monitoring during the surgery for one reason or another, these would all be reasons to use the ultrasound energy device. However, you still have to be careful, and I'll get into some of the safety concerns in a minute. The mechanism of these ultrasonic devices is that they have two different ways of cutting the tissue, and they also can coagulate vessels. I'll go into some more detail about that later, but they have a special type of cutting called cavitation, which allows you to cut the tissue while you dissect at the same time. So that's one of the major benefits of the ultrasound energy devices. But first, just to describe how this device works, you have to generate the ultrasound energy. And so within the handle of the instrument, there's a transducer. And within that, there's a stack of piezoelectrodes, which are positioned between metal cylinders. When this transducer is activated electrically, these piezoelectrodes are then excited, and they convert the electric energy that's going into the handle into mechanical energy that vibrates the cylinders, and this creates the ultra-high frequency with the linearly oscillating surface that's then attached to the solid shaft and ultimately the jaws. So that's the basis of how the ultrasound energy is created. Before it gets to the handle, the energy goes through a generator. For most machines, this is going from plugged into the wall and going through the generator before it goes to your device. There are also some devices now that have lithium batteries that power them instead. As I mentioned, once it gets to the handpiece, that's where the electric wave goes from electricity to mechanical energy, and then ultimately into the device where it's mechanical energy only. Now moving on to clinical applications, when you're using the device, there's usually two settings, a min and a max. And generally the max setting will cut quickly, which is advantageous in terms of there's less time for thermal energy, and we do see less thermal spread than in other advanced instruments. However, if you do have any vessels within that area, there's very little coagulation on the max setting. The min setting, however, which can be fine-tuned from 1 to 5, it cuts much slower, so there's more time for vessel sealing. There's also more time for thermal spread, however, and collateral injury. To get into a little bit more detail about how this device works, as I mentioned, there's two different ways that the cutting works. The first one is by squeezing the blades together, you'll be cutting the tissue, and unlike the bipolar instruments that we just heard about, where lifting up is not a good idea, with the ultrasound devices, you do actually want to lift up if you're trying to cut. You can lift the instrument up, but you can also have an assistant grab the tissue so that you're having more tension on the tissue and more pressure on that blade. So that's one of the ways you cut. This is usually on the max setting, and you can actually adjust what's called the blade excursion, which is the amplitude of the blade oscillations themselves, in order to change the effects of this. The second way that cutting can happen, the way I mentioned before, which is called cavitation, is unique to the ultrasound energy devices. With cavitation, basically the vibrating tip of this device is placed in a tissue that has less protein than other tissue, things like fat or areolar tissue. And in this situation, the intracellular temperatures are raised secondary to the oscillation of the blade, just like they would be anytime you're using the device. But in addition, the oscillating tip creates a zone of low atmospheric temperature. And this is effectively going to reduce the boiling point of the intracellular water. So you heard earlier about with RF electrosurgery, with monopolar devices, if you want to get that vaporization, you have to raise the temperature up to 100 degrees Celsius. With the ultrasonic devices, you can actually get that vaporization at a lower temperature. So in addition to the cellular vaporization, there's also additional gases products of cellular vaporization that will help expand the tissue planes, and that will facilitate dissection, which it's where they come up with the word cavitation. Then we talk about the coagulation function. So how does it seal vessels? So first of all, it's the coactive coagulation, which was described also with the monopolar discussion. But in this case, it's obviously not with the RF energy, but with the ultrasound. So the vessel walls must be compressed together, so you have to close the jaw tightly. And the protein in the vessel wall will denature and form a sticky coagulum. The vessel walls then adhere together after the energy source is removed, and that's how you get the vessel coagulation. And in this talk, it mentions an upper limit of 5 millimeter vessels, although some of the newer devices do allow up to 7 millimeters. So this slide just depicts what I mentioned before, that with the ultrasonic devices, you can have the tissue effects that you desire at a lower temperature. Here I'm showing an example of the fact that with ultrasound devices, you actually have less lateral thermal spread during activation than you do with some of the other advanced energy devices. And what you're seeing here is you could use an ultrasound device in order to create an enterotomy before you do a bowel anastomosis or a gastrotomy or any other various reason where you would like to make a hole in the tissue, but you don't want to have this thermal spread laterally, which later on in a few days might necrose and cause a leak at your anastomosis. So the ultrasound energy devices are really good for that. One of the downsides to these ultrasound energy devices is the residual heat. And what you're seeing in this slide is an example of injury to the bowel that occurred because these devices are frequently used for dissection, and they're very good at that. Unfortunately, the user has to remember that the actual active jaw stays very hot longer than with other devices. So from 20 to 45 seconds after activation, this device tip, the active jaw, can still be extremely hot. So then if you go to grab another area of tissue or dissect something, you may end up with a significant burn injury. So overall, some of the advantages, these ultrasound devices are very versatile. They can graft, dissect, cut, coagulate. In addition, since they can do all these things, there's often fewer instrument exchanges. They can divide, as it says, they're up to 5 millimeters, although, like I said, some more recent devices do claim to divide up to 7 millimeters safely. And the active blade can be used to mimic a monopolar device. Another advantage is the minimal thermal injury, that we're functioning at lower temperature in the target tissue. And as I mentioned at the beginning, there's no electricity in the patient. So those are all major advantages. However, overall, some of the disadvantages, the vascular sealing is affected by the surgeon's technique, so you have to really keep the jaws closed and have the true coactive coagulation for vascular sealing. In addition, the retained heat in the blade and shaft can burn tissue when you go to use the device again. Although there is the advantage of not having smoke, there is significant spray, so it can make visualization difficult if there's a lot of spray. Also, it's a more expensive technology, so while the handpieces can be reused or reprocessed, at the same time, this also can contribute to blade fatigue and failure. So overall, if you're using newer instruments, it is very expensive. And one other disadvantage that's not on the slide is that some of that coagulum can build up on the blades, and then you have to activate it in saline or water in order to clear them off. So the evidence on these, there's a lot of papers out there looking at advanced bipolar instruments versus ultrasound energy shears. And again, there's proof with the earlier devices that the bipolar can be used for 7 millimeter vessels. And the earlier ultrasound energy devices were limited up to 5. And there aren't large trials yet showing the 7 millimeters, but some of the newer devices are saying that 7 would be safe for ultrasound as well. So the overall take-home points with the ultrasonic devices, as I mentioned, it's very versatile. There's minimal spread of energy, no electricity going through the patient, which is really key for patients with pacemakers and other devices like that. And you don't need to worry about a dispersive electrode. You don't have to worry about where it's going to go or what metallic implants they might have. And then the disadvantages, again, it's expensive. It's probably not as good at vessel sealing as the advanced bipolar instruments are. And there's a lot of technique involved, both with the coactive coagulation of vessels and also a lot of technique involved with how much tissue tension you use, what your blade excursion settings are, and those other factors in terms of cutting through the tissue. And that is all I have. So hopefully we've caught up on time a little bit. Thank you.
Thank you very much, Jaysa. This was a great illustration how clinical Fuse can get and how relevant it is to you becoming a good technical surgeon. We talked a lot about the patients with implantable devices. This is one of the conundrums. We face a patient in the middle of the night that has a pacemaker, and how do we deal with that patient if he needs a laparoscopic appendectomy or cholecystectomy or some other procedure? And I, for example, tend to get very nervous about that. And Dr. Tom Robinson, who is the chief of surgery at Rocky Mountain VA Medical Center in Colorado, is one of the national, I would say, world experts on how to deal with this problem, how to describe it, and how to understand it, and what to do to prevent a potential problem. Dr. Robinson is also the co-chair of the Fuse committee and has been with Fuse from the very beginning. Please, Dr. Robinson, let us hear about cardiac rhythm management devices and surgical energy-based devices.
All right, thanks, Pascal. And I do think this is a topic that's cross-cutting to all surgical disciplines and I think is poorly understood. So I don't have anything to disclose. And, you know, Amin really set me up with his talk, the first talk, which outlined that there's very high voltage in the that's given off by the monopolar generator going to the active electrode. And this very high voltage energy gives off electromagnetic interference. And, you know, you may be familiar with this if you, you know, activate your active electrode, and sometimes it will affect the monitor of your laparoscopic tower, and you get little lines across it. That's electromagnetic interference. And that can also disrupt any type of device that's implanted in the patient. And so what I'm going to talk about in the next 10 minutes here is the effect, particularly of the monopolar instrument, so that's the quote-unquote BOVI that we've been talking about, on cardiac rhythm devices. And I'm going to reference mainly two papers that are out there. There's two guideline statements. I would say they're not very high quality in the sense that there's not a lot of evidence out there in the literature to base their recommendations on, but they are based on the latest expert opinion on how to use monopolar instruments in the setting of a cardiac rhythm management device. And you're welcome to email me, and I can shoot you these papers. You know, I have PDFs of them, and you can probably just get PDFs of them at your local institution. But these, I think, are very useful. All right, so I'm going to cover three topics today. The three topics are, I have a little outline here. Okay, so here's the three topics. So we're going to do preoperative evaluation, intraoperative monitoring, and then intraoperative minimization of electromagnetic interference. And so this is really designed if you're in the middle of the night faced with a patient who comes in with a pacemaker or a cardiac defibrillator, and you don't even know which one it is. How do you manage that? And so that's going to be the first few minutes of this talk. And this talk also is really geared for answering the questions on the Fuse examination correctly. So let's go to the preoperative evaluation. And I would tell you that the best way to figure out what kind of device a patient has is probably to ask the patient. And most patients will carry around a card with them that will tell you what their most recent settings are, what type of device is in. But if your practice is like mine, not all the patients have that kind of information. And so this is a way that if you're standing there at midnight and you have to operate on somebody, this is a reasonable way to manage it. So there's two questions that you have to ask. The first question is the device a pacemaker or a cardioverter? The second question is the patient pacing dependent? And so you, without the patient telling you, and without an interrogation device or knowing how to use one of the interrogation machines, this is the way you can do it. So to determine whether it's a pacemaker or a cardioverter defibrillator, you can get a chest x-ray. So you can get a PA lateral or just simply an AP. And so what you're looking for is this right here. And you can see this radiolucency. This is a coil. And what that coil does is it stores up a charge that allows the cardioverter defibrillator to shock the heart to change its rhythm. So you can see on the cardioverter defibrillator there's this long, wide opacity, so it's wider than the rest of this wire. Where in a pacemaker that doesn't have a cardioverter defibrillator, there's no radiopacity that's wider than the wire at the end of the lead. So I hope that everybody can see that radiopacity right there. That means it's a cardioverter defibrillator, and we're going to treat that differently than if it's just a simple pacemaker. So the second piece of information that we need to know is the patient pacing dependent? So how we're going to figure that out is we're going to get a 12-lead EKG. And most patients are going to have ventricular spikes. So you can see the pacing spikes right here. Oh, I'm pointing with the wrong arrow. So here it is right here. So you can see the pacing spikes marching out. If the spikes are in front of most or all of the P waves or the QRS complexes, because it's clearly in front of the QRS complex right here, you can assume that the patient is pacemaker dependent. So here is on the left is an atrial pacemaker, and you can see the pacing spike. It's consistently in front of all the QRS complexes, so you should assume that that patient is pacing dependent. So based on those two pieces of information, so the first was, is it a pacemaker or a cardioverter defibrillator? And the second piece of information is the patient pacing dependent? Then we're going to be able to manage the patient in the middle of the night. So here we go. So the monitoring, which I put down here, is similar for whether you have a pacemaker, which I have in this first slide, and the next slide is going to be the cardioverter defibrillator. So the monitoring, it's standard ASA monitoring. And so you need to have an arterial line or a pulse oximetry. That's the probe that goes on the finger. You should place transcutaneous pacing pads on all of the patients. And you should evaluate the device before leaving a cardiac monitored environment. So postoperatively, because you've been using electrosurgery on the patient, you could disrupt the lead, the sensing lead, or the lead that's pacing the patient, and you can change how that works. So you actually need to interrogate it before you leave a monitored setting. All right, so here we go. So for the pacemaker, given this monitoring, we have for a pacing-dependent patient and for a not a pacing-dependent patient. So let's start with the pacing-dependent. So you should use short electrosurgical bursts, place a magnet over the device for procedures that are above the umbilicus or that use extensive electrosurgery, and have a magnet immediately available for procedures below the umbilicus. So if you have an incarcerated umbilical hernia, you can just go about using monopolar electrosurgery, using it judiciously, and you should have a pacemaker or a magnet in the room. If the patient is not pacing dependent, you can just have the magnet available in the room. So this is right out of the guideline statement. So the next slide has the same monitoring, which is down here, but it's going to change the management strategy because it's now a cardioverter defibrillator. So this was the one with the large radiopacity towards the tip of the lead. That's that coil that stores the charge. All right, so for a pacing-dependent patient, place the magnet over the device to suspend tachyarrhythmia detection and use short electrosurgical bursts. And then the second would be for a not pacing-dependent, place a magnet over the device to suspend the tachyarrhythmia detection and use short electrosurgery bursts. So this would be a reasonable algorithm to use if you're in the middle of the night and you do not know what kind of device the patient has. So the next thing I'm going to switch to here is the intraoperative monitoring, because there's several questions on the Fuse exam on intraoperative monitoring, and I again think in the middle of the night this is something that's useful to have in your toolbox. So you need to monitor the patient beyond the simple EKG rhythm strip. And the reason for that is because when you activate the active electrode, the electromagnetic interference, the same electromagnetic interference that's going to interrupt the cardiac rhythm device can interrupt your EKG rhythm strip, and you can see that right here. So the monopolar instrument is activated, and then all of a sudden the rhythm strip goes kind of haywire. So you need some other type of pulse monitoring. It could be a arterial line or a pulse ox, and then you can see, is the patient, is this electromagnetic interference up here, or is this truly affecting perfusion? Then I have a second example of that just on a different rhythm strip. And you can see here the rhythm strip goes flat, but yet you can see the patient is still perfusing during this time, so you wouldn't make an intervention. But the key on the questions in the fuse exam is simply that you need to have monitoring beyond the EKG rhythm strip because electromagnetic interference can affect the EKG rhythm strip itself. All right, so the final topic is what you can do as the surgeon to reduce the amount of electromagnetic interference, which is just a long word for how do you minimize the electrical disruption of a cardiac rhythm device in the operating room. So here you are, it's the middle of the night, like what can you do? And I'm not going to walk through these right now, but I'm going to have kind of 2 slides on each one of these topics, and we're just going to kind of march through them here in a few minutes. All right, so the first one is intuitive and obvious. It's the proximity of the active electrode to the cardiac implantable electronic device. So here's the practice advisory statement. Here's some evidence that we generated. It was a number of members of the FUSE group got together, and we actually put pacemakers and cardioverter defibrillators, implantable ones, into pigs under anesthesia, and then we actually used the monopolar instrument in various settings around them to try to really gather evidence around these. So this is what the FUSE group kind of found, and this is what the practice advisory statements say. The practice advisory statements basically say the further away you can keep the active electrode, the less electromagnetic interference there's going to be. I think that's intuitive. We found that was true. But the problem with this statement, of course, is that you can't necessarily change where the surgical field is, right? So, if the patient's got a problem in the upper abdomen, you're going to be operating in the upper abdomen, and it's hard to kind of change that. So I'm just going to show you a little bit of evidence from our manuscript. What we did is we activated the active electrode. You can see 0 centimeters all the way to 40 centimeters. So we activated on the skin 0 centimeters below the sensing. So a defibrillator or a pacemaker will typically sense right here at the tip of the lead. And so we activated it right over the top of it at 0 centimeters all the way down to 40 centimeters. And you can see there's a real dose response where you decrease the electromagnetic interference that's affecting the cardiac management device, which is up here, the further away you get. And you can see that it plateaued at around once you're about 10 centimeters away. And I think that's how the guideline statements, they get that rule of thumb that if you're operating below the umbilicus in an adult, it turns out the umbilicus is a little bit more than 10 centimeters away. I think that's a good rule of thumb, is that if you're below the umbilicus, that you can pretty safely use the monopolar instrument. All right, the second one, and this is really now this is the first modify. I don't think this is modifiable where you operate, but this is a modifiable one, is you can change where your current vector pathway is, and that sounds like fancy language, but I'm going to show you a graphic to just kind of look at it here in a second. But the concept is you should put the dispersive electrode, that's that grounding pad, the big sticky pad, you should position it so that the current or the straight line between your active electrode tip and the dispersive electrode does not go through the cardiac rhythm management device. So here's a great example of it. All right, so if we're operating down here, we're doing an X-lap on somebody, where do we want, because we can change where we put the dispersive electrode, and I don't think anybody would put the dispersive electrode up here, say on the left shoulder, right? But if you put the dispersive electrode on the left shoulder, the energy and the current would go straight this direction and go right through your cardiac rhythm management device. And so that would not be what's ideal. What you want to do is place it so that the current vector goes down and away for it. And I think where this gets particularly relevant is when you're doing operations either on the neck or on the arms. And Mark Rosner, who was really the founding Fuse member, was an anesthesiologist at MD Anderson and did all sorts of melanomas on the arms. And he would literally, so they would be operating down here in the hand of the arm, he'd put the dispersive electrode right here. So the current would come from here to here, and it would never go up around the generator. So being a little bit creative about where you put your dispersive electrode so you avoid the current, which is a straight line between the tip of the pencil going to the dispersive electrode, you have to avoid that going through your device. All right, so the next one is orientation of the active and dispersive electrode cords. This isn't addressed by the guidelines, but it turns out the tip of the active electrode, the tip of the pencil, that same energy that's been giving off there is also traveling all along your cord. And so you should not drape your active electrode or your dispersive electrode cords adjacent or close to the patient's chest where the cardiac rhythm management device is. Instead, you should drape them from the foot of the table. So if you're doing an X-lap or a laparoscopic operation, all of the cords from the electrosurgery generator should be draped from the foot, because these cords carry the same voltage that can disrupt the function of this pacemaker as the tip of the active electrode. So all you do is you just roll your generator down to the foot of the bed, and then you'll minimize the risk of that one. You can also use alternative devices. I know when I go to the operating room, I like to use the monopolar instrument. That's kind of the workhorse. But having said that, I think the guidelines say, and there's good evidence out there, that the amount of electromagnetic interference is different for different devices. So the monopolar instruments are here. This is the Bovie we talked about. The plasma devices are the worst. So what is a plasma device? That's like the argon beam, right? So the argon beam has a spark gap between the tip of the active electrode and the tissue. You need a lot of voltage to get that energy across that spark gap. So this is going to be your highest one. So you really probably should avoid the argon beam and the plasma devices. But the best devices, so if you could preferentially use a traditional bipolar device, which has very low voltage, a advanced bipolar device, which typically those have tissue sensing parts of the sort of how the device works. So bipolar, and the other one is ultrasonic that Jason just talked about. Ultrasonic devices really don't give off any electromagnetic interference. Their cords do have some electromagnetic interference, but once it hits that piezoelectric electrode in the handle, there's no more electromagnetic interference down that shaft. So preferentially, if you could use those, that would be a good idea. All right, so what other things can we do? We can minimize the power setting on the generator. That's the 30 watts coag. You could preferentially use lower voltage outputs, which a mean went over. So that's the cut mode, which has 100% duty cycle, or blend mode, and you should preferentially not use coag if you can help it. And then if you can alter your surgical technique, so desiccation, the generator for say 30 watts power, the generator is going to give off a lower voltage to the active electrode if you're desiccating, which is touching the tissue, versus fulgurating, where you're sort of creating a spark gap and you're arcing the energy over to the tissue. And this is my last slide here, just to review the modifiable factors that you can do to minimize electromagnetic interference on the cardiac rhythm management device. So number one, you can lower the power setting. The cord location should be from the foot of the bed, and the cord location should never be draped across the chest. The dispersive electrode location, you should always put the dispersive electrode so that the current vector goes away from the device, so it doesn't go through the cardiac rhythm management device. Or you can use an alternative energy source, and the common ones would be the bipolar or the ultrasonic. And Pascal, with that, I think I'll turn it back over to you.
Well, thank you very much. That sums up the webinar. There's a lot of things to chew on for everybody. I know it's pretty dense information. In fact, we condensed all the information that was in the Fuse curriculum from about 10 hours to about a couple of hours. I'm not sure if we have any time for a great panel here at this point, but I would like to make sure you all got the message that I wrote into the chat box. go to www.fuseprogram.org, go to the didactics button, and you can sign up for the Fuse curriculum for free. They just ask you a few demographic questions. You can create your own password and sign in, and then you can take a Fuse curriculum online. It's a multimedia program. It has CME credits that you can get for 12 hours. But most importantly, once you take this curriculum and you understand everything good, you are ready to take the Fuse certification exam. And this will allow you to get access to all the slides that you saw today, plus the videos, plus everything else, and start your career as the Fuse electrical surgery energy device champion at whatever institution you're going to be at. Stephen, do we have any time, or should we, are we ready to fold? I guess we are done. So thank you very much for participation, and see you all at the SAGES meeting next year in Seattle. Thank you very much. Yes, Stephen.